Would a potential solution be this idea of small committees? So let's say somebody is experiencing chronic pain, localized or general, that they would go to their general practitioner, but in the room would also be somebody who understands somatic medicine, trained clinical psychologists who understand somatics, that the body and the brain are linked through the nervous system, and could also assess, possible psychological roots of the issue. And then somebody in the room who can make behavioral, nutritional, maybe even supplementation-based, safe supplementation-based recommendations. And then the physician who can say, and in addition to that, I think the person should have on hand, a 5 milligram dosage of a prescription drug that if they need it, they could take. Yeah. And I think it would provide a lot of protections against, potential adverse effects of any one of those things in isolation. There's great protections in having people meet in groups for lots of reasons, and the person would feel very well cared for. So again, small committees of people with diverse expertise pooling together to treat people from a, for lack of a better word, a more holistic perspective. Why not?
I mean, you're describing the dream. I think that's exactly what we need. Interdisciplinary teams that can provide integrative care, recognizing that in this day and age, there's not one person who has all the expertise to help us figure out how to best manage our health challenges. I think what we have not figured out are a couple of things. Number one, who are all the right people who need to be in the room, or the sort of virtual room, if you will. The second is, how do we create a structure, a healthcare system where that can actually happen with efficiency, where it can be reimbursed appropriately? But that's what we should be doing. And then the third leg of that is the group experience for patients, right? And there's increasingly more clinics and healthcare systems around the country that are working on creating group experiences where patients who all, let's say, are working on their diabetes come together, let's say once a week, and they meet with the healthcare practitioner. That might be in addition to their individual appointments. But there is so much power in groups coming together, groups of patients who can find community, who can help each other, learn from each other's experiences. That's highly underutilized right now in medicine. But to really do this well, Andrew, I think means that we have to pull back from the model we have had for years in medicine, which has been a highly individual type model, which says, okay, you go to your doctor, you see your doctor one-on-one, you get everything you need. Maybe you need to go see a specialist. Okay, then you wait a few weeks, get another appointment, drive 30 miles, go see somebody else. Maybe they're connected to the electronic health system. Maybe they're not. Maybe they know what was discussed. Maybe they don't. Maybe they'll call and talk to their primary care doctor, but maybe they won't because they're too busy. And then you as a patient are stuck trying to piece all this together.
While often in pain.
Well, yeah.
In physical and emotional anguish. Yeah. I'm not referring to my own experience, although I've had mild examples compared to what other people have dealt with. But people with chronic pain are irritable for understandable reasons. I mean, it's or maybe somebody is veering towards suicidal depression. Then there's the interpersonal effects. I mean, I feel like the crisis is one of a lack of efficiency and thoroughness. And again, I'm not throwing stones at the medical profession. I like you believe that it's a collection of mostly well-meaning people trying to do their best, but the specialist model and the referral model is incredibly cumbersome.
It really is cumbersome. And like you, look, having worked with many medical professionals over the years, like these are colleagues who I deeply admire. I mean, like they're there for the right reasons. They want to help people alleviate suffering, but they too are feeling burned out and frustrated by the inefficiencies of the system. Because I'll tell you, one of the greatest contributors to burnout for doctors and nurses is a lack of self-efficacy. It's seeing a patient who has a problem in front of you and feeling like you can't get them the help that they need. That is the greatest paper cut, if you will, to the sort of spirit of clinicians. And many find themselves in that circumstance where they either find that they know what's needed, but the system is throwing up prior authorizations or other insurance hurdles and preventing their patient from getting that care, or they are kind of at the edge of their expertise, right? This happens to pediatricians and primary care doctors more broadly all the time with mental health, right? Most of the mental health care that's delivered in this country is delivered in primary care offices, right? Now, primary care doctors didn't necessarily train specifically and only in mental health, yet they find themselves having to manage a lot of that, including increasingly complex substance use disorders and treatment-resistant depression. And they need help figuring that out. But if you don't have a lot of resources to get that referral, to collaborate with mental health professionals, and you're stuck on your own figuring that out. And so, I think the pain is being experienced mostly by patients, but also very much so by clinicians. And that's why that overhaul is needed. And I think, look, a lot of this is, I'm not a healthcare economist per se, but I will say that a lot of this, I think, is tied into the business model that we built around medicine. The notion that, we're paying individual people for individual services and individual procedures that are done. While that has some merit in some cases, what we really care about is that the person is getting efficient, integrated, multidisciplinary care overall. And so when health systems, for example, come together and say, okay, rather than sort of focusing on the amount I'm getting reimbursed for every procedure, we're going to take more of a value-based approach here where we say, okay, we've got a certain amount of money to care for certain people. What's the most efficient way for us to provide them care? Recognizing if we don't do that, it's not only bad for them, but our costs in the long term will go up because we're not getting reimbursed for every procedure. We're getting reimbursed for the care, overall care that we're taking for a patient. So there are more of these value-based models that are being adopted, certainly in 2010 when the Affordable Care Act was passed and when other measures were taken in the Obama administration in Medicare, like that really pushed value-based payment models forward. And again, they're not perfect. They need their own tweaks, but I don't think that the existing financial structure that we had in medicine was serving us in terms of delivering the kind of multidisciplinary, integrated, efficient care that we increasingly need.
Tough problem, but through recognition of tough problems comes good solutions. That's my belief. I'm an optimist at the end of the day. You mentioned mental health. Lately, you've been increasingly vocal about the crisis of isolation.
Just one second, Andrew. Before we go there, just one thing about the tough problems, right? You're exactly right. And the problem is the longer we take to acknowledge and address these tough problems, the more entrenched the interests become that profit from the status quo, right? So if you look at the private insurance industry right now, there are so many challenges we have right now with patients and clinicians saying that they know what care is needed, but it gets denied. They know what care is needed, but prior authorizations, get thrown up there and required, even for a medicine that clearly your patient needs urgently. I've had the experience myself of having a family member who has needed a medication for an urgent situation, and then being told that the pharmacy will not fill it because it requires a prior authorization, but that can't be processed until the weekend is over because no one's in the office to approve the prior authorization. And you're thinking to yourself, does this make any sense? Like, this is an urgent situation. My family member needs this medication. I've also had the experience as a doctor of fighting for my patients who have been denied care by an insurance company and being on the phone saying, I'm sitting here in front of my patient. I know that they are sick. I know they can't go home. I know they need to be in rehab. There's nobody literally to help them at home, but then not having like the rehab bed approved by somebody who's not even there, right? And there's also just a practice that we've seen time and time again where insurance companies will also just burden clinicians with more and more requests for information before they will agree to reimburse for services that have already been delivered for a patient who needs them, which is just creating more and more barriers, hoping that if you're a small time doc out there who's got, shingle that you put up, you don't have a lot of resources, how are you going to keep fighting all of this and sending more and more paperwork? And so eventually you'll just give up. We have a lot of problems right there in an industry that should be delivering care, often is doing good things, but too often I think is allowing barriers to be put up to the care that's needed. And this is particularly true with mental health. I know we're going to talk about that, but mental health care has just been such a difficult thing for people to get in our country. And part of the reason, there are many reasons, but one of them is that insurance companies historically did not reimburse adequately or in the same level for mental health care as they did for physical health care. Or if they did, they would only reimburse for a limited number of sessions that you could have. But if you're a mom out there who sees her child struggling with depression, you're really worried, you don't want to be told, you know what, you can only get 3 sessions. That's it. What are you supposed to do after 3 sessions, right? And so what has happened is that even though in 2008, there was a law passed called the Addiction, Equity, and Mental Health Parity Law, even though that was passed to try to close that gap, there were many ways that insurance companies were skirting it, right? So one, the law wasn't even being adequately enforced for many years. But 2, insurance companies sometimes would say, okay, we're reimbursing adequately. But when you look in the network, they had very few providers. So you really couldn't access somebody, right? So that was a problem for patients. And then the other challenge is that they would say, okay, you can see somebody, but you've got to complete this prior authorization, have that completed by your primary care doctor, et cetera. Again, throwing up more and more barriers. So very recently, in fact, just a few weeks ago, President Biden just announced that we are, from as an administration, putting out a proposed rule to actually strengthen the mental health parity law to prevent some of these, what I think of as abusive practices, because they're preventing people who need care from getting it. And if you've ever been, as I know many people have been who are listening to this, if you've ever been in a situation where you or somebody you love has struggled with a mental health concern, what you need in that circumstance is help. You don't need to be filling out paperwork. You don't need to be waiting 3 months to actually get care. You don't need to show up and be told you only have 2 more appointments. You need to know that help is there when you need it. And a lot of these denials are being issued to people who have done their part of the bargain. They've paid their premiums. They've held up their end of the bargain, and care should be there for them when they need it. So anyway, this is something that upsets me a lot because I have seen too many patients over the years struggle without the care that they deserve and should get because of barriers that are being thrown up by industry. But I say all that just to say that when you take on big problems, you will run up against entrenched interests. And that's a fight we have to take on. We can't shy away from it. We can't say, this is politically too difficult. Like one of the things I'm very proud of is that we're finally negotiating on drug prices through the Medicare program, something that should have been done decades ago. But it's finally happening now. The administration just decided this has got to happen. It was passed by Congress. This is good. And it makes no sense that we would pay more than we need to and pass the cost on to taxpayers when we can negotiate. And we got to if you're collecting taxes as government, you should be doing your best to make sure every one of those dollars is being spent well, right? Because somebody took money out of their paycheck, didn't use it for their family, didn't use it for their kids, and they gave it to the government for good reason, because that supports first responders, police officers, a whole bunch of services that we need. But the responsibility in government is to make sure that money is being used well. And to pay more for medications than we should makes no sense at all, especially for patients and taxpayers.